speech therapy degrees, they make all of the words complicated. So that whole bio is because of that. Because you go to school and it's the Biobehavioral Studies program. I don't know why they named it that, but that's fine. So, you heard a little bit about me and my bio. I'm going to go through a little bit more as we continue, but before I do that, I kind of want to know who you are. And in the light of HIPAA and being sensitive to survivors and caregivers and everybody else, I'm going to ask you to close your eyes in a minute. And don't worry, I'm not going to touch you. I'm staying up here, so don't worry about that. And what I'm going to ask you is the reason why you're here, kind of, or how you're related or connected to brain injury, or how you're not related or connected to brain injury. Does that feel okay with everybody? If you don't feel safe closing your eyes, that's okay. We'll let you slide. Is that okay? Okie dokie. So everybody close your eyes. And if you are a survivor of brain injury, including stroke and various other ones, raise your hand. Okay. If you are a professional, whether medical, rehab, anything like that, that works in the area of brain injury, raise your hand. Okay. If you are a caregiver, a loved one, a friend of an individual who has survived a brain injury, please raise your hand. Wonderful. And lastly, if you're just here because you knew my name, just kidding. Members of the community who thought this might be interesting, raise your hand. Awesome, you can open your eyes. Wasn't that bad, right? Okay. So here's what's interesting to begin with. Me and Christine and Ron went back and forth actually about naming the presentation. My original name was Benefits of Cognitive Linguistic Treatment, and Ron had mentioned we need something more public friendly. So we came to there's more to speech therapy. And actually that's what we're going to talk about today. We're misnamed as speech therapists a little bit, but we're going to go through that. So first, a little background on me. I have this cool clicker, so if I mess it up, I'm sorry. Awesome. Okay, so I went to Columbia. I went to Geneseo's program is no longer running, unfortunately. I have my ASHA, Certificate of Clinical Competence, again, a tongue twister because we're speech therapists. I'm licensed in New York. I was previously licensed in New Jersey, and I also am a Reiki master, which is an energy healing technique, and I also am a brown belt in the NIA technique, which is a movement, holistic movement activity. They don't have it much in Buffalo. It's on my list. Okay, so right now I'm at Buffalo Hearing and Speech in Amherst, and I've been there for a little over a year, well, like a year and a half. I see patients who have sustained brain injuries, and I see adults only. I don't work with kids. They're cute. I have nieces. I like them. I don't want to work with them. Previously, I worked at a place that's now being rebranded as the Center for Brain Injuries in the Cognitive Rehabilitation Department in Edison, New Jersey. The director of that department, who trained me for 11 years, is Dr. Keith Cicerone. Dr. Cicerone is actually the co-chair of the Brain Injury Task Force for the American Congress for Rehab Medicine. He's one of the top COG rehab guys in the country. And so I learned from him for 11 years, and that's where I got my expertise. Related, I helped run a social recreational program for individuals who survived brain injuries for 5.5 years. I was the kind of co-director of that. I lectured at Columbia, which was known. I'm on the advisory board of Headway now, which is pretty cool. And I started helping a little bit with ECMC and their development of a social recreational program with their staff. So that's a little bit about me. So, misconceptions of speech therapy. And you'll notice I crossed out speech therapy and I wrote speech language pathology, because that's our real name, right? We get the speech therapy tag, and then we tend to get pigeonholed into what we actually do as a profession. So when you think of speech therapy, what populations do you think of? Anybody have any ideas? Who gets speech therapy? Children. See, that's the only answer. Stroke victims, yes, there's more. So, here's the thing, is that the amount of individuals who can be seen by a speech therapist, it goes from birth to death. I do not do this, but there are speech therapists who help little babies learn how to eat in the neonatal unit. I don't do that, but there are speech therapists, speech language pathologists, I'm going to keep correcting myself on that do that. Kids who stutter, of course, language development, articulation, autism, feeding for toddlers and other little kids, young adults and teenagers with learning disabilities, voice disorders, elderly population who have swallowing disorders, teachers with voice disorders, vocal performers. These are all people speech language pathologists work with. And of course, brain injury. So guess what? We do more than just kids. Not just little kids who can't say their R's, right? We're bigger than that. Unfortunately, it's not really known. The other thing that's interesting is the environments a speech language pathologist would work in. What's your first thought? Schools. Yeah, I don't work in school. Never did. Schools, hospitals, private clinics, nursing homes, home care, hospice. We are everywhere. You just can't see us. So finally, education. We're trying to spread the word that SLPs do more than kids. We do more than schools. We do so many different things. And what's interesting is almost every patient that gets sat in front of me during an evaluation says, I don't know why I'm here. I can talk. And then I go into my spiel. And the spiel is the differences between speech language and communication. Your speech is your actual ability to produce the sounds, right? So after a stroke, sometimes you can have one half of your face not have as much muscle tone, something like that, and you're slurred. So that's speech. Speech is your mouth actually producing the sound. Then we have language. Language is the words, the actual words that come out. You can't find the words. That's your language, right? The words themselves. Communication is a big, giant bubble that includes both speech and language, but also cognition and your ability to have a conversation. So when someone comes in front of me and says, I don't know why I'm here, I can talk. I say, I know you can talk. We do more than that. Did anybody learn anything in the last few minutes? All right, cool. Speech therapy is bigger than you think it is. Right? So what I specialize in is what's called Rehab, or cognitive rehabilitation, but we like to shorten things because everything's hard to say. Rehab. But before we go through that, I want to kind of go through what my definition of a brain injury is. And some people might disagree, but this is mine. When it comes to brain injury can be any insult to the brain. So we have our typical traumatic brain injury, which is what you hear of. And I just remembered one that's not on this list. Stroke is a brain injury. An aneurysm is a brain injury. A tumor or a tumor resection is a brain injury. A seizure disorder, multiple sclerosis, Parkinson's disease, Alzheimer's, dementia, chemobrain. I had a patient who had uterine cancer, and the chemotherapy she received actually hurt her neurologically, and she had cognitive difficulties because of it. She didn't have a traditional brain injury, but the chemo actually affected her brain. The one I didn't put on here is CTE, the whole football thing now. That would be, again, a brain injury. Remember, a concussion is a brain injury. We don't usually treat it that way, but it is. Does anybody have any questions so far? Cool.
I have a question.
Sure.
In terms of the concussion, you hear a lot about the football players.
Mm-hmm.
Now, if they sustain one concussion, could that result in some sort of brain injury, just one concussion?
From my perspective, yes.
Okay.
I have had people who have had sustained one concussion and have difficulties.
Okay.
So, a concussion typically is a swelling of the brain,
Okay.
which then would hit your skull,
Okay.
and then that could then cause issues.
Okay. Thank
But
you.
from my perspective, not everyone would agree with me.
Okay.
So, okay, this is a lot on this slide, but common brain injury related cognitive changes. So we have attentional deficits. So changes in your ability to pay attention. This includes being able to sustain your attention, so focus your attention, Divide your attention, so do two things at once. Alternate your attention, so going from cooking to doing something else and coming back. This could be that you get easily distracted, tasks not being completed, because you get pulled by something shiny and you never come back to the other thing. And there is some level of normalcy with that. We all have a little bit of a attention difficulty, but when it comes to a deficit, it truly affects people's lives. Other difficulties you could have with attentional deficits: difficulty cooking, paying bills, completing work and home tasks, or completing school assignments. You can have memory impairments, so learning new information can be challenging. Being able to recall conversations you've had, or being able to follow directions that are multiple steps. Can be memory impairments. Difficulty with executive function, difficulty problem solving or formulating goals. Difficulty with initiation and inhibition, so getting started and then stopping yourself from doing something. Self-monitoring, so knowing what you're doing and modifying your behavior if you need to. And then also time management. So these are all would fall under executive function. Even further, cognitive changes that could occur is disorientation for time, place, person, or situation. So you don't know the date. You don't know where you are. You don't know who you are. Slowed processing speed is one of the biggest ones we see. It takes longer. Problems interpreting sensory information. So being able to understand what's coming at you, whether it's visually or whether it's through your ears. Reduced insight or awareness of problems. This is also a very, very prominent difficulty, is your awareness that there's something wrong is usually decreased. Poor emotional regulation or emotional control, I'm going to go into that a bit later. And then changes in energy and fatigue. So your endurance, whether it's cognitive energy, your emotional energy, or your physical energy, is all reduced after you sustain a brain injury. So this is also a big slide. You have it in front of you too, so if it looks too overwhelming, you could also cover some of it up. It'll help. Okay, communication changes that are related to the cog changes. Difficulty with word retrieval, disorganized when you're expressing your thoughts, so you're kind of all over the place. Difficulty understanding what's being said or what's being read. Difficulty following conversations, needing extra time to comprehend information. Not providing enough information, so you're under-elaborative. Providing too much or inappropriate information, so what's known as verbosity, you provide too much information. Or being disinhibited, meaning you kind of don't have a filter. Anything falls out. Also losing your train of thought, difficulty staying on topic, slurred or distorted speech, that falls in the speech category, right? Injury-related disfluency. Some people can sustain a brain injury and then have a fluency disorder because of that. Neurogenic stuttering, it's called. Your brain can't figure out how to make your mouth make the sounds. That's called apraxia. So these are some of the brain injury-related communication changes. Any questions? Go ahead.
Does apraxia usually come with aphasia?
It can, but it also doesn't have to.
Does apraxia ever happen separately?
Mm-hmm.
So you can have apraxia but not aphasia?
Yeah, you could. It's what's interesting, and we'll go into all the different how different brain injuries are. But there's so many pathways in the brain that you can get almost any kind of plate of stuff. You could have just apraxia and no aphasia. You could have aphasia with no apraxia, or you could have both. And the same thing goes with reading disorders. So, which I neglected to leave on there. Reading disorders. There are some reading disorders where you can write but you can't read. There are reading disorders where you can read and you can't write. And there are reading disorders where you can't do either. So everything splits in any direction you
So
can.
like in her case, there's apraxia, aphasia, she can't read, she can't write.
She got a big hit.
Oh, she had
Big hit.
SAH.
Yeah. Yeah. But it does separate out. Okay. So how can a speech therapist, a speech language pathologist help? I'm going to keep doing that. That was not on purpose, by the way. Okay, so cognitive rehabilitation, also known as cog rehab. As a speech language pathologist, that falls under my umbrella. I can be an expert in cog rehab, and I am. I've been doing cog rehab for 13 years, and I love it. It's my favorite population. That's why I stick with it. So the first step is being able to identify what's going on. So what areas of cognition and communication are not going well? And that's kind of complicated because a lot of the assessments we have as speech language pathologists don't catch this stuff. So you have to know what you're looking for, right? Our job is also to provide education on the changes that could come later, on the changes that are happening. And when someone asks, did I do this before the brain injury? I'm probably going to say no. Because if you're noticing it now, it's probably due to the injury. Our job as rehab professionals is to support the caregiver and the survivor. So to help you through this. Developing personal communication and cognitive compensatory strategies. So we come up with the tricks that help you get the stuff done that you need to get done. Assisting with generalization of those strategies to home, to work, to school, to wherever it needs to go. And then as you go back to life, whatever life has for you, our job is to then step in and go, how's it going? Do you need more help? And if there's something specific that's not working, what can I do to help? So as a speech language pathologist, this is what we're in charge of, believe it or not. Now the other thing that comes in with the evaluation and identifying areas of need is what is often known as the invisible injury. So those who sustained a brain injury, unless you have a physical manifestation such as a hemiparesis or paralysis or anything, your injury is invisible. You can walk around day to day and no one knows something happened. You can kind of squeak by. There's good and bad to that. So no one knows anything happened, so you can go to the grocery store and no one bugs you, or no one looks at you different. However, when you're trying to explain that something's wrong and you don't know what to do, people don't believe you. They think you're fine. You look good, you look great. Oh my God, how you feeling? You look great. But what they're not seeing is all of the stuff that we're supposed to look at, right? Okay, so when we think about assessing deficits, this is another crazy slide. If it's too overwhelming, you don't have to look at it. This is called the key. My supervisor who hired me first straight out of grad school created this. She taught courses at Kane University in New Jersey. And what she said is, as a speech language pathologist, this is your job in evaluating how a person is doing. So you take, and I won't read it all, you take all of these cognitive areas on this side, you look at all the cognitive areas, and then you look at the speech and language assessment and intervention areas, so auditory processing, verbal expression, pragmatics, reading, writing, oral motor function, and you have to look at how any difficulty in this side then affects this side. And you have to look at the impact of cognition on all of those things. Now, unfortunately, there's no test that does that. You just kind of gotta do it. With practice, I can usually learn what's going on with the patient within an hour, for the most part. I get chunks later on, but within an hour I can figure most of it out. But I'm always learning. There's always the next thing that happens and the next thing that happens. So that's kind of looking at how do we assess it.
Can you explain pragmatics?
Sure. Pragmatics are your ability, in a nutshell, your ability to have a conversation. Pragmatics includes providing enough information in a conversation, using the correct facial expression in a conversation, not standing too far or too close in a conversation, staying on topic, not providing enough information. It's kind of that flavor. It's your ability to participate in a conversation. Okay, now I'm going to go through, sure.
What percentage of your patients, because what you just said is it's kind of an invisible injury, right? Because you see all adults, when kids go to speech pathologists, they're not thinking, right? They can't say there are. But as adults, are most of your patients driven by a patient identifying a need, or is it the impact on their supportive family members that really lands that patient?
That is a good question. I don't know if I can give you a percentage, but I can explain a little bit. So when it comes to the awareness piece to it, that's where that divides the line, right? So if they have an impairment in awareness, which is my next slide, which is interesting that you brought that up. If they have an impairment in awareness, more likely than not, it's going to be a family member, a caregiver that's bringing them and saying something's going on. They're not aware of it, but I see it. But if the impairment in awareness isn't as big, if they're more aware of what's going on, it's the individual who's driving it. But it depends on the injury and how the cards fall. Speaking of awareness. So, awareness is the key to rehabilitation with adults. That's the school of thought that I was taught in. The idea is that if you're not aware of the problem, you can't do anything about it. So when you think about awareness, there's 3 levels in rehabilitation. At the bottom level is your intellectual awareness. What that means is you're able to verbally say, somebody told me I talk too much, but I don't think I do. Someone told me that. Someone told me I don't have a good memory, but I think my memory's fine. So they're able to verbalize this idea of being intellectually aware of a difficulty. So someone told me I do this. The next level, which is a lot about what rehab is, rehabilitation, is the emergent awareness section, which is you're going about your business and you're doing your stuff and all of a sudden you realize you forgot something. And in the moment you go, oh, there's that memory thing they told me I do. Or you start talking and you get off topic and then you go, oh, that's that thing my therapist said I do. I get off topic. I'm starting to notice now. That's emergent awareness. Now the ultimate goal is to reach the top point, which is anticipatory awareness. Anticipatory awareness is knowing I have a memory problem, doing something about it before it happens. And when it comes to rehabilitation with an individual who survived a brain injury, the ultimate goal is anticipatory awareness. I know I provide too much information, so I'm going to stop myself before I do that. Now that's a long journey up the pyramid. It's a very long journey. And what's interesting, when you think of a typical speech language pathologist, I didn't say speech therapist, good job, Jess. When you think of a typical speech language pathologist who works in a school, who works with kids, they're actually not doing this at all. When it comes to kids, most of the time, especially early intervention, you're trying to sneak that therapy in. You're playing with blocks and then helping them mold their behavior, but you're not telling them what they're doing wrong. So, as a speech language pathologist, from my perspective, is if you're going to go into brain injury, you should specialize in it and know your stuff. Because a person who typically works with children may not know that it actually is a better approach to come at it from an awareness perspective than the play therapy perspective. And also, now it's true children have brain injuries. I don't work with them. Adults are responsible for their own behavior. So if they're not aware that something's wrong, they're never going to do anything. And then on top of it, I think this is the next one. Oh, that's not the one I thought it was, but that's okay. This is another tool I use in treatment. It's called your Cognitive Energy / Emotion Scale, a CES. This was developed in my old rehab in New Jersey for a program called the Intensive Cognitive Rehabilitation Program. Again, more big words. So a CES is a tool that I use that looks at something that's important that's often overlooked when it comes to a brain injury. And that's an individual's ability to control and manage their emotions. When it comes to after a brain injury, a lot of times, individuals who have sustained one lose control of this. And what happens is this actually directly affects your ability to communicate, and it directly affects your ability to think, remember, and problem solve. So a little explanation of the scale. 1 to 5. 3 is the best. Not a typical scale, right? It's usually 5 is the best. Here, 3 is the best. And when you think of yourself as a 3, I'm a 3 when I'm clear-headed, I'm not tired, I'm well-rested, I feel content, I'm good. It's kind of the take on the world feeling, a 3. As you go up the scale, a 4 would be something like frustrated. This is actually one of my patient's scales. So she has feeling tension, stressed, Her pain is increasing. She needs to take deep breaths. She feels on edge. She feels frustrated. That's a 4. A 5, anxious, unable to control emotions, feeling overwhelmed. Those are high emotions on that end. On the lower end, you get the heavier emotions. So we have emotional upset, in quotation marks, people don't understand. And 1 is exhausted, completely spent, depressed, can't face things. So you have this scale of emotions that we all experience, and it's both emotion and energy. So if you're tired, you're going to be on this end. And it's normal to fluctuate at any given time in the day. It's normal. Now, the curve you see is actually your ability to communicate, your ability to think clearly, your ability to problem solve, and your ability to do anything with cognition or communication. So you see it at 3, it's at its peak. And as you go to the outer edges, they go down. So your ability to do those things goes down. Now, Tom, you want to be my guinea pig? What's your CES?
Right now?
Yeah. 3.5.
Yeah, 4.
4? Okay.
It was 3 before you asked.
I know. Exactly. Now, that's the thing though, is that any little thing can trigger a change, right? Make you nervous. Now, an individual who has not sustained a neurological incident or a brain injury can operate pretty well at a 2 or a 4. I can operate pretty well at a 2 or a 4, especially if I'm busy. However, I know that I'm slipping further than that if I go to the copier and I forgot why I went. Right? So I'm running around, getting stuff done, blah, 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 lots of patience. And I know that if I get to the copier and I'm like, shoot, I gotta go back and figure out why I'm here, I know I need to chill. I need to get closer to a 3 so I'm more focused and I do my job better. When you think of an individual who sustained a brain injury, 2 and 4 are not good places to operate. You make mistakes. And when you get upset about those mistakes, you make more mistakes because your CES gets higher. And then after that, maybe you're so depressed that you couldn't finish what you tried. Now you're down here, and how are you expected to get to the next thing? So this is a tool we use in treatment to identify, first of all, what your CES looks like, and then coming up with strategies, how do I get to where I want to be? And then also looking at what triggers a change in my CES. Is there a person? Is there a situation? And then when it changes, how do I use those strategies to get back to where I want to be? So this is a very, very good and interesting scale. It doesn't work with everybody, but I use it a lot. Do you have a question?
When you use that, do you rate people based on what you're receiving, or do you have them rate themselves?
So I have them rate themselves, and then if I, not always.
Okay.
So I have them rate themselves, and if I don't believe them, I usually question. So I have a woman who always wants to be a 3. She's like ready to go. She comes in, I am a 3. And I'm like, okay, how's your pain? She's like a 5. I'm like, okay, well, then you're not a 3. And which is okay, and this is a learning journey for everybody too. I'm learning the person or the patient, and they're learning about themselves, and they're building awareness of what's going on. So if I don't believe them, I will definitely question it. But again, and then there's also some individuals who just can't use it. They're always a 3, which is impossible. We're not always a 3. So that's an interesting tool that can be used with individuals with brain injuries by a speech language pathologist. We do this stuff. Cool. All right, so speaking to the apraxia versus aphasia question, amongst other things, this is a very helpful tool when someone asks, when will I be better? My answer is, I don't know. But I can tell you a little bit about what I do know about. When it comes to an individual's recovery, there's really multiple factors that come into play, right? So you have the individual's pre-injury characteristics. Were they chatty? Were they always chatty? Were they always quiet? What's their level of education? What's their background? Where did they start off before the injury happened? You have the injury variables, including the severity, right? The the severity, the situations where the injury occurred, how it occurred, how long were they in a coma, do they have any anterior grade or retrograde amnesia, so before the injury, forgetting, or after the injury, forgetting, all of those injury kind of variables. You have the individual's reaction to the injury. How did they react in the moment? How are they reacting now? Are they now grateful and they're going to live their best life, or are they very, very upset or depressed about it? Everybody reacts a little bit differently. And then you have the environmental influences, and that has to do with their support network, whether it's caregivers or rehab professionals. So did you get to the right people at the right time, or did you go home and wait to get better? Because I'm going to tell you right now, if you walk away with anything, going home and waiting to get better does not work. It doesn't. We have to get you to the people that you need to see. I'm trying to think if I can get anything. So when you think about like the idea of the environmental influences and that being one of the the 4 kind of pieces to how a person recovers, if you don't get the rehab you need, how are you supposed to get through that part? So a little piece to that. Any questions? Yeah?
I'm 37 years old. And
Me too!
And I don't always act my age, and I want to. And there's a thing my mother said to me, and I always remember it, and she's right. She goes, you know, you might be 37 years old, but you're not your age in your mind. But I want to get there. I just don't know how to.
Okay. Maybe we need to get you to see the right person.
Thank you.
You're welcome. Okay. Moving on. When we think of recovery from a brain injury, the model for rehab, this is New York University's, NYU's head trauma programs model. This is from a while back. This is 89, but it still holds a lot of weight. You might not be able to read it on your slide, so I'll read it for you. You can see this is kind of a mountain, right? So recovery is a mountain. It doesn't get smaller. The idea with getting yourself to, yes, a speech language pathologist to help you get strategies together is first engaging an individual and understanding where they're coming from, building a rapport. So that's the first piece for me, is to build a rapport and trust with my patients. The next piece is improving their awareness. You think of that awareness pyramid. If they are unaware of the deficits that they're dealing with, it's making them aware. Then you think of compensation, coming up with strategies to compensate for the deficits that they're experiencing. Working on mastery of those strategies. Working on being confident with strategy use, so being able to take them out in the world and do it. Some acceptance of the changes that occurred. There are things that I cannot fix. And I don't like saying that, I wish I could, but there are certain areas of deficit that I can't fix. We can compensate as best we can, but we may not be able to fix it. So the acceptance piece is important. And this is showing the person climbing to their new identity as a survivor. And this is not an easy climb. I don't think it would be an easy climb for anybody, let alone an individual who's gone through some trauma and an injury. So what I'm questioning, and I don't think it's anybody in this room, is anybody a neurologist? Cool. And if you are, you don't have to admit it. I'm getting patient after patient where the neurologist is saying, go home and rest. Wait to get better. I got one of my patients because she had a friend in New York who knew a neuropsychologist in New York who got her to Dr. Letty of the concussion clinic, and she lives in Clarence. She was struggling and she needed help. She lives in Clarence. No one told her what to do. No one told her, go find a speech language pathologist who knows this stuff. She can help, they can help you. There's not many boys, so they can help you. How do you expect to climb this mountain without help? I don't see that as a reasonable expectation. Ooh. Brain injury rehab. This is again my top line here. Don't wait to get better. Get survivors referred to the correct people. Seek out the education you need. Many repercussions can be avoided if the right education is provided. One of the biggest things I noticed, specifically with quote-unquote mild injuries, is that if a person is left to their own and not helped, they tend to then react emotionally to the changes. And then the changes and the deficits blow up bigger. So you have a small attention deficit, a small word finding difficulty, and you're left on your own, and you kind of stew in your own juices. And it gets worse, it feels worse. So when I see someone after they've been recovering for 6 months, and their deficits seem huge, when really they're just so upset about it that they got bigger. So if you get to them to the right person first, we avoid that. We avoid the 2 months of me dialing down the deficits, right? Believe what they're saying. They are not making up symptoms or deficits. I'm finding this in many of my workers' comp cases is the insurance people are going, you're faking. No one would choose this to fake. Not in my opinion, anyway. And it's happened across the board. You're faking, and after 12 weeks of getting better, if you're still not better, this is a conversion disorder, which means it's all in your head. You're making it up. I say believe them, because they're not, right? A medically mild injury does not need mild repercussions or symptomatology. I have a patient who was in a car accident, was diagnosed with a mild concussion. She is hypersensitive to sound. She has to wear sunglasses all the time. She has a stutter, and she has no memory. And that's not an emotional reaction. That is what's happening. And that was a mild injury that had major repercussions. And just because a scan, MRI, CAT scan, does not show evidence of an injury does not mean there isn't one. So your question about concussions, right? You get a scan, it's probably not going to show anything. But that's not the deciding factor. When you think about the majority, not strokes, because strokes are typically more focal. When you think of a more diffuse injury, the injury is in the axons of the neurons. That's where it is. Diffuse axonal injury. Do you have another question?
Yes, I have another.
Sure.
In terms of head injury, my head injury was back in an automobile accident back in 1984. And it was a major auto accident. At the time, no one really understood, head injury. And it went for several years before I really figured out something was wrong.
Right.
I came back to my job after being off, after being in coma and the whole shot. I couldn't remember anything. I tried being retrained. I couldn't remember anything. And my way of dealing with that was avoidance. I was a manager at the time. I couldn't do the management, so I went into sales, something where I could be alone and work at my own pace. But that was something I just didn't get the help at that time, and it took me basically almost 10 years to actually really figure out what was wrong and start seeking help. And basically, I started going to Headway at the time, and it helped me in terms of dealing with it. But at that time, no one really understood, head injury.
Well, yeah, and then I'm just going to also, a little thing, kind of like speech therapist versus speech language pathologist. The goal is to switch from head injury to brain injury.
Yeah, braided.
Yeah.
Right.
And that's okay, because we've been calling it head injury for years and years and years. The goal is to switch to brain injury. But to your point, and to the slide, is you needed the education. You needed it, because you didn't know what was happening, right? And you kind of off flailing on your own. And then I'm sure you stirred yourself up a little bit as well, saying, am I crazy? What's going on here? And that's why a lot of it is education, and that's why I'm here today, right? My goal is to spread the word. My goal is to let people know. There's more to speech therapy. You can get help from a brain injury. Right? Thank you for sharing. And so finally here, what now? I have no idea. I'm just kidding. Spread the word. Tell your friends. Tell your family. Put it on social media. There's more to speech therapy. Speech language pathology. Know that there are people in organizations like Headway that can help. It's sometimes challenging to find, but there are people out there. So if you or someone you know is struggling, get them to the right people. That's important. And And then my goal is to work to spread the, you know, the view of the profession at large. So I put it all over social media. There's more to speech therapy. I'm trying to correct my own language because I'm used to calling myself a speech therapist instead of speech language pathology, because we cover so much more than just little kids who can't say their R sounds. Ron?
So we notice a lot of times on cases that run through Headway that go in our waiver program, is that speech pathologists only appear very in the beginning. Very hard to see someone who's been, you know, after 6 months having a speech therapist, speech pathologist. You know, what's your opinion of why that is? Do doctors understand that you do all this other stuff?
I don't think they do. That's why I asked if there are any neurologists in the room.
I
So,
think we're pretty safe with that.
okay. So here from my experience, and now I'm coming from two worlds, right? So I worked in New Jersey for 11 years in a rehab unit, and I was the cognitive rehabilitation unit, so we were outpatient. We had 6 neuropsychologists on staff, 4 speech therapists, 3 OTs, and 3 PTs in an outpatient cog rehab unit. In the same hospital, we also had an extended recovery unit for individuals who had sustained more severe brain injuries and were not medically stable to go home. But they were stable enough that they weren't acute injuries. On top of that, we also had the brain trauma unit, and that was the acute brain injury rehabilitation section. Now in New Jersey is actually smaller than Lake Erie, if you want to picture how big it is. And in New Jersey, we were one of at least 4 competing adult brain injury rehabs in any one given moment. And that was just mine, the one I was in. We were the Center for now brain injuries, it was head injuries. We were the Center for brain injuries, and we were one of 4. In Buffalo, I feel like the rehabilitation piece to it is maybe not as widespread. ECMC does a great job. You know, I know Buffalo Therapy Services has a handful of people, and Bennett Rehab has people, but there's really not a big integrative care association. Now, when it comes to do medical professionals understand what I do? Absolutely not. I've had one of my newer clients say she talked to her, her neurologist said you don't need speech therapy. She does. And her psychologist, one of the two, can't remember, said, what do speech therapists have to do with brain injuries? And this is why I'm like, I need a taller building, I need more money. I'm not asking for money. But the idea is that the misnomer of speech therapy is what gets us partway in trouble. Is that we're speech language pathologists and we deal with cognitive disorders. And so I do my best to share that with as many people as will talk to me. But again, this is kind of where we're at. And the other thing in terms of it being in the beginning and not later on is that I specialize in this. This is what I do. I don't do kids. They're cute. I like them. Great. This is what I do. But at Buffalo Hearing and Speech, I became somewhat of a resource for speech language pathologists who had been working for a long time, who had been licensed and everything, that they get to a point with a patient and then they're like, I don't know what to do, and they say, call Jess. Because I can think of the next thing. So in terms of focusing on brain injury and focusing on cog rehab, I had the luxury of working in a unit for 11 years and being trained in it. And the other speech language pathologists don't have that necessarily. So you could get to a certain point, and I'm very sensitive to what needs to be done next or noticing deficit areas. But somebody else who doesn't have my experience may get to a point of 6 weeks, 6 months, and say, there's nothing more I can do for you, because they don't have the experience or the education. Because this is not a thing that gets focused on in school. You don't learn a whole lot about it. I lived and breathed it. I was doing it at Columbia when I was there. I was doing research with adults with brain injuries. That's what I did. That's what I focused on. And then I got hired to continue to do it full time.
But in answer to this question, isn't it mostly insurance driven?
I'm sure we could get into a healthcare insurance driven conversation. I'm not going to do that today. But when you think about it, and I have this conversation, when it specifically with workers' comp, because they have very much control. When it comes to individual health insurance, a lot of times it's 30 sessions, that's what you get, and you get another 30 the next year. Workers' comp has the ability to just go, nope, we're done, and not give any more. And I always tell my patients, they don't care what's going on with you. They're an insurance company. Insurance companies make money. That's what they do. Their goal is to spend the least amount of money as possible. So, and you're just a number. You're just a claim number to them. They don't know you. So, the rest of the slides that were included, I don't know if I left them up here. I'm not going to go through them, but what I provided you guys with is a brain injury education guide. And it goes through a bunch of different areas that could be troubling for an individual who has survived a brain injury, and some strategies to help you out. So I'm not going to go through those, but you can have those to go home. And this was developed in my old rehab unit in New Jersey. So that's for you. And then I'm open to if anybody has any questions about it.
Do you accept Medicaid?
Does Buffalo Hearing and Speech accept Medicaid? I believe so.
They're both, yeah.
I believe so, yeah. I have some medication.
30 sessions a year, you said?
That was a random number.
Okay.
If it's Medicare-ish, so independent health Medicare, Medisors, those kind of things, it's usually 23.
Okay.
So it has to do with the Medicare therapy cap, and so you calculate it that way, and it turns out to be about 23 sessions.
Okay.
In terms of taking patients?
Yeah.
Yes, I have my card here too.
Hey Jess, I have a question, maybe a statement I first of all. I think jumping off what your question was, one of the things that this has brought to light is the lack of understanding of the impact of the speech pathologist down the road for the duration of the injury, right, in the long-term implication. Has any of these organizations looked to better educate the physicians in this area, right? Because we have a medical program in Buffalo that's amazing. And do they, nationally, internationally, do they understand the impact that the speech pathologist can have on their patients? And do organizations drive that message for something like this to the medical community? Because it feels like that's kind of the gap.
That's a good question. I don't know. I know, again, New Jersey, keep going back there. Brain Injury Association, or Alliance now, of New Jersey is heavily, heavily, heavily involved. And they have big gun name doctors in brain injury, right? So Dr. Cicerone is the top guy in the States, probably internationally too. Like, the military was coming to him to say, do you approve, what do you think of COG Rehab? Is it evidence-based? That kind of stuff. So he's got a big name, so he pulls money and he pulls power. And he's been doing it since the 80s, so he's got like a good foothold there. I mean, there's Headway, and I don't know if that's, I don't think that's one of our PowerPoint mission statement
Well, it
things.
can be.
Can be, all right, there you go.
We have you presented today. I think that the problem we have is that you have to get a group of physicians who are on board with you to kind of lead to the other physicians. It's kind of, you need physicians speaking to physicians. And
All
even
right,
though.
Dr. Letty it is then.
Yeah. Well, we had Dr. Letty, but I think we need more than Dr. Letty. That's kind of the problem we have. We need like a consortium, like a bunch of physicians that kind of on board to kind of drive a little bit.
Mhm.
We've always had one or two docs here or there, kind of like, yeah, that's pretty cool, that's good, let's go with that. We really haven't had, and this is in general in the area of brain injury, we really haven't had a solid medical from the MD side to kind of like help drive it or at least align with us.
Mhm.
So that would be like something we'd like to have. We've had more from kind of like this, speech pathologists forward and counselors that way. We've had that always. But we've had trouble getting the docs to kind of help lead us. Because docs are kind of like, are like vets actually. They kind of want to hear from other docs.
Well, and I have that since I had this conversation today, the idea of why do they not know,
Definitely.
right? And I said, I'm trying, right? My name's Jess Young, I'm not the head of some random department somewhere, I'm just a lowly speech language pathologist. And I don't have a name here, right? In New Jersey they do me, but now I'm back in the Buffalo area. So that's the challenge, is that you're right, you need the big names to almost be part of the driving force, because that's what people listen
We need
to.
more. We need like docs.
stuff.
Like if you, or maybe you could help with that, if you could get maybe a couple doctors to really kind of push it. In this area, it's pushed a lot from the MD community. So if somehow, you know, and Headway, we're open to that. What you can do with that. I mean, we always have had issues with referrals of trying to get people to understand brain injury. It's not been easy.
Right.
So, so that's something we would like to do. But I think that would be the answer, if we can get more from the MD community, so. And anybody here who has some ideas or things like that, you know, reach out to the MD community, but this particular area is not one that they're really kind of like getting into.
So, maybe a little myopic, but I'm looking at it from a nursing perspective and IUD. And one way to make change is, you know, talk about primary prevention, right, community health. So you go for the younger generation. So getting into the education departments is where you need to get those dots. They don't want to talk to you once they're making them sixth graders. So if you get them while they're in school, you can start educating them, you know, for ID, you know, what you need is, you walk over there and start teaching. But that's where maybe we need to start trying to.
That's an excellent point. Excellent.
Get into the school of medicine and start having youth come in and talk to them about.
Okay, I'll go. I'm right there. Who knows the best?
Just a suggestion, so maybe an acronym, you know, so
Yeah.
pursue primary prevention.
The doctors here, I went to Dent, and we tried to get the doctors to work together. They don't want to.
I think it might have something to do with that 60-day
Yeah,
salary.
that's why I'm bringing it up too. They don't want to get together to talk it out. That doesn't help us.
Right. I understand where you're coming from. It makes sense. And again, we're kind of all fighting the uphill battle, right?
I'm a caregiver, and back in 1983, when my brother came out of coma, he had a lot of rehabilitation, including quote-unquote speech therapy, because he couldn't talk. He had to learn how to walk, talk, get everything. He recently had, he shattered his left humerus, and there were a number of things that went on, but it has, the whole experience and the trauma has changed something in his head. He used to be very, very patient, but he's more easily upset. And although it's gotten a little bit better recently, for a while we had a hard time both finding a word, but also, on the other hand, he would try to say something, and I'm pretty good. I'm pretty good at listening, and I couldn't understand at all what he was saying.
Did it sound garbled? Or was he like?
Completely, yes. And so what I'm wondering is, at this stage, it's now, you know, umpteen years later, would he benefit from a speech pathologist?
Sure. How do you break his leg?
No, he broke his humerus.
Oh, how do you break his, whatever that is. Oh, the funny bone. I remember.
No, it's this bone.
Okay, then how do you break it? Did he fall?
Yes, he swung around and fell off a chair. He's 200 pounds, so.
Did he maybe hit his head?
Well, he may have. He may have, and he may have hit his head again recently.
Then, first of all, I think it's always give it a shot.
They told me, you know, he didn't hit his head, but.
Believe them when they tell you. Just kidding. I would say that it wouldn't hurt to try and look at it. And look at, okay, are there new things going on? Because obviously you're noticing new
Yes.
things. So that's a pretty good indication that something new happened, right? And I would say there may be some things that an individual can't compensate for or can't fix because they're longer, but why not try to look at the new stuff? It doesn't hurt it.
Right. Thanks.
Anybody else? Almost perfect on timing.
I mean, can you check for some key indicators, though, that maybe practitioners in the area could say to physicians to identify why maybe someone should go back to speech pathology?
So a description of what they're dealing with? Or
Well,
like
because usually they say they topped out, they're fine, a couple of years go by. And, you know, compensatory strategies, I mean, some of these things that you're talking about, we actually do it on our programs. We're independent living skill trainers, we're not,
Yeah.
no, they're kind of, they're paraprofessionals. I I just wondered, we always have trouble because remember, the insurance company won't do without the MD recommendation.
Right.
The MDs think that there's no point to it anymore, he's basically at his baseline and we're not gonna get much further. Is there things that maybe we could think about to point out that would help maybe folks getting additional therapy at a later stage?
To convince, things to point out to convince an MD.
Yes.
So it's a high order.
Not, I mean, don't put you on the spot, but, I mean, you could write me an email.
Right,
But I
yeah,
mean, you
yeah,
come up and that's your thought of like, maybe something to be helpful.
Well, I think that some of the tools that maybe a typical speech language pathologist who has not specific high rehab training, things like the awareness idea, the idea of awareness, the idea of cognitive emotional energy, and how that directly impacts an individual's performance. And so the idea of those influences, but even, I've gotten to the point where even a physician whose patient says, I can't find the words I want, that does not equal speech therapy to them. So we're talking a basic level. So I can't find the words I want to say.
Yeah.
That's where we're at though. Like I can come up with a whole bunch of different ones, but when they say, I'm losing my train of thought, speech therapy doesn't pop up.
Sure.
If they say my speech is slurred, we're golden. So maybe that's it. Everybody who has a cognitive issue, go in and say, my speech is slurred. And then you'll get to the right people. It's a little workaround.
First, you're gonna talk to them.
Yeah. But,
I do know that over at the University of Rochester Medical Center, they're doing a lot of stuff with hearing and stuff like that. There's speech therapy.
and Nazareth has a brain injury clinic, yes? Yes, so Nazareth College has a brain injury clinic. And they do stuff at UB speech language pathology
Yeah.
too. They have a clinic there.
Yeah.
But again, it's education, right? So.
Is there any other questions? Okay, well, we'd like to thank you very much. Okay, so what's happening now is that we're going to have the advisory council in like about 5 minutes. Thank you all for coming.